Okay, good afternoon, everybody. It's such a pleasure to be here with you this afternoon for this workshop. My name is Carolyn Catilli. I'm actually a patient education specialist at Penn Medicine in Philadelphia, as well as being an adjunct professor at the American International College in Springfield, Massachusetts. And I was co-chair of HCEA's development of the guidelines. And so I've just had the pleasure of working with this project from the very start and look forward to presenting it to you today and having you interact with it and give us your feedback and your reactions. And I am very blessed to have my partner with me today, Jeanette Helm. Jeanette, would you like to introduce yourself?
Good afternoon. I'm Jeanette Helm. I am the Director of Education and Professional Development for the Indiana State Medical Association. I'm also adjunct faculty at Indiana University at Indianapolis, teaching in the Fairbanks School of Public Health and the Executive Education Program. I have worked in organizational development and education and training in healthcare for many years. I've been a member of the Healthcare Education Association for many years, and so I was thrilled to be a part of the project team that worked on creating these patient education guidelines, and I'm very happy to be co-presenting with Carolyn today.
And Jeanette and I both had the privilege of being presidents while this was being developed, with Jeanette before me and then me. So, all right, I'm going to go ahead and start sharing my screen so you can see the slides. Jeanette, if you could keep an eye on the chat, that would be great.
I will.
Okay, and let me go to the slideshow. And move to the side here. Jeanette, can you see our faces to the right bar? Is that blocking the slide?
I can see our faces.
Okay.
And I can see the slides well too. Looks good.
You can see everything?
Yes.
Oh, then I'll open that back up again. Okay. All right. So this is called Putting into Action the HCEA Patient Education Practice Guidelines for Healthcare Professionals. So how did we get to this point? Well, back in about 2017, 2018, we were sitting there. HCEA had just finished, they had finished the scope of practice for patient education. We were looking at doing certification in patient education, but realized that it was a very financially investing endeavor. So we thought, can't quite go that direction. We didn't have quite deep enough pockets. So we thought, well, what really could we do? And we're looking around going, you know, there's no concise guidelines for frontline healthcare providers. There's little tools here and there. You know, there's the PMAT, there's the CDC Clear Communication, which actually didn't come out to 2019. There was some proprietary things from different organizations, but there really wasn't anything out there for frontline healthcare providers. So we thought, you know what, here's a need. We've already finished the scope of practice. Why don't we just roll on to that? So we talked about, what do we already know? We already know about the Health Literacy Universal Precautions Toolkit. We already know about the Suitability Assessment of Materials, the SAM that was done by Dok and Root. We already knew a bunch of other tools that were out there. So then we started pulling together a work group, and we pulled together a work group of about 27 individuals who were interested in working on this project. And one of the first things that we did is applied for a national network of the Library of Medicine's Health Literacy Grant. And what we used the grant for was to pay the library to run our literature search. And we ended up working with the University of Pennsylvania, which is at that point in time was called the Biomedical Library. And we supplied them with basically, and this took a lot to get through this, but it was much harder to develop search questions than we ever thought it would be. It took months to get through this, to be honest. But we finally landed on 4 questions that always had the underpinnings of health literacy with the questions. But basically, what were the best practices for assessment, planning, implementation, and evaluation? And so they ran that process. That took several months to pull all that literature together. To be honest, we were hoping they were going to hand us assessment and we could start working on it, and then they'd hand us planning, we could start working on it, but they said it really doesn't work that way because these topics were so interrelated. We had to sit and wait till they were finished, which took several months. But once we got our hands on the literature, we had over 10,000 articles. We did get rid of duplications. And then at that point, we had a team of about 20 of us that decided that we would look at the title of the article and look at the abstract and decide whether it was pertinent to patient education guidelines, because there were lots of different things that pulled in under assessment and evaluation, particularly with training of healthcare professionals. That was probably one of the biggest overlap. So we went through all 10,000 articles. We also had a search of gray literature, and we decided what was pertinent, wasn't. And then once we got that whittled down, I think we got it down to about 354 articles, which was pretty amazing that we were able to whittle it down that far. And then we went through each article and we did a summary of the article, what the title, who the authors were, what type of research study it was, what were the outcomes, what were the strategies, what Melnick level was it. So we went through all that, and then we looked at it and said, okay, but now how are we going to look at this to actually write the guidelines? So we also had grouped it into whether it belonged to assessment, planning, implementation, or evaluation, which we know it as API. And so we then divided it into the A, the P, the I, and the E groups, and we assigned people there. And we said, okay, now go ahead and look at these articles and see what commonalities, what strategies were coming about. So we had people work on that and look at what the strategies were. And then we stepped back away again and said, okay, what are the most striking research articles, most dramatic change? What are the most common things we're seeing? What were the best run studies? What were the most pertinent studies? And that's how we came up with what was included in our guidelines. So the first thing we did is we did a draft review with our organization at one of our meetings. So we had over 100 people review the guidelines at that meeting and gave us feedback immediately. And being someone who had worked on this for a long time, when they started to give me feedback I didn't want to hear, I had to bite my tongue, I had to be honest, because you put so much work into it. And it was really funny. It was the dichotomy that just seemed to go through this whole entire process. Is one group would say this is still too long, and the other group would say there's not enough, and those were questions we just constantly asked ourselves: is how do we be thorough and concise? What's important to have here? How do we write it that everybody can understand it? What if it's a topic that needs to be a little bit more beefed up, but you don't want to make this too long? So this struggle just continued. Actually, one of the biggest struggle we had was which should be bigger, planning or implementation? And they're very related to each other. And I will joke that, the blows were almost beginning to fly as we were discussing this. But in the end, we decided that most of the information should really be under planning, because it should be everything that you should consider before you go in and educate the patient, which was really implementation. So we came up with another draft after that, and then we sent this draft out across the country. We were involved with the Physical Therapy Association. I have connection with the orthopedic nurses, the navigators across the country. We sent it out to that. We sent it to educators. We sent it to any groups that were willing to take a look at it in any discipline. And so they returned surveys to us and gave us feedback, and we literally went through comment by comment and decided, whether that was something that we could work in the guidelines or whether that was just pushing the guidelines in a direction we didn't want to, because we wanted it concise for frontline caregivers. And so then we published the guidelines in November of 2020. So we're just about a year out at this point. And we've gotten some great feedback. We've had some institutions contact us on being able to use the material to put into their websites and different organizations. And so it's been a great ride. So that kind of gives you the background of how we've gotten here. So we have, and I wanted to ask, so apparently we have some polling questions. I'm sorry, our tech person, are you able to do the poll for us?
Yes, I can. I can totally push that right now.
Okay, so what are the sources of evidence used to develop the HCEA guidelines? So basically, we want you at this point to plug into the poll. What were the sources of evidence that we used?
And I believe it says single choice, but you can actually choose multiples here.
Is it working? When do you switch over to see how they're turning out?
Whenever you're ready, I can end the poll and we can see the question.
So there's no way for them to keep going while the poll is running.
So the poll is, people can still answer, but you can still continue. I can just end it and then you'll be able to see the answers.
That'd be great. Thank you.
Yeah, so let me know whenever you just want me to end it.
I think we're good, Jeanette, don't you?
I think so.
Go
All
right
right.
ahead. Very good. Excellent. I will tell you that, yes, definitely research articles. You heard that. Government reports, all that was part of our gray literature. Podcasts were not. Professional organizations, though, with white papers, we did take a look at that. For example, the Joint Commission Statement on Health Literacy, we took a look at. And then dissertations were actually came up under our gray literature also. So great, you're right on target.
And it looks like they were only able to choose one. So you did very well with that. Great job.
Thank you. All right. So I wanted to show you what the guidelines usage data looks like. Now, if you have our slides, this slide looks different because I basically got an update at the last minute yesterday. So I wanted to slip this right in. But at this point, we've had over 12,000 hits, 7,000 to our homepage. When it comes to the API process, you can see there have been about 2,800 hits, and they're broken down into assessment, planning, implementation, evaluation, with assessment getting the most. Jeanette, way to go. You were in charge of the assessment section. The resources, we had 1,300 hits there. And basically, divided between reference by list versus reference by alphabetical. 707 people tuned into the quick guide, and we have 400 people looked at the frequently asked questions. This shows you our table of content. And as you can see here, we have the homepage, the frequently asked questions, and then we go into assessment, planning, implementation, evaluation. Then we have appendices, because like I said, there was information that needed more robustness to it. So we put a lot of things in the appendices to provide that additional information. Plus, we're linking them to more information. Then we had references by list, which you will see when Jeanette shows you the guidelines, and then we have references alphabetically. We ended up with about 253 references in the guidelines. And then for those who thought it was too long, we went ahead and did a guidelines quick guide. So that gives you the very basics of the API. So that's what it looks like. No, I'm trying to get my slide to go here. One more time. There we go. We have another poll now. Are you able to put the poll up? It says, which part of the patient education process would you like to spend more time reviewing? If you could give us that feedback, we will adjust our presentation to what you are looking at, what you would like to look at.
And we also had a request from someone to put the URL in the chat. So maybe we can work on that during one of our breakouts.
That sounds good. You also are going to see it on the slides as we go on also. All right, I think probably everybody's had a chance to choose by now with the poll. If you want to go ahead and close the poll. Okay, implementation. Interesting. All right. Well, that'll give us some guide. You may be a little disappointed when you get to implementation, because our approach really was implementation is basically doing what you planned. So maybe we will flip between planning and implementation, since they cover a lot of the same topics there. And evaluation coming in a strong second. All right. Let me close this out. Here's the URL, as you can see, but we will put it in the chat. And this is what the homepage looks like when you land on the patient education guidelines. So we just wanted to let you know what it looks like. And at this point, Jeanette is going to take over. I'm going to unshare my screen, and she's going to walk you through the guidelines on the internet, so you know what is there. Jeanette, I have stopped sharing.
All right. So if you will give me a moment. Now, Carolyn, I am not able to see anything from our Zoom meeting. So if you will monitor the chat for me and just break in if I need to address something, that would be great.
Sounds marvelous. I've got it.
Let's see. I think I need to share my screen, correct? Are you
Yep.
seeing it?
Not yet.
Okay. Here we go. Let me do this first.
There you go.
There, and I can see the Zoom as well. Just had to get everything in the right sequence. So is everyone seeing the HCEA homepage? And I'm scrolling.
I am.
Great, wonderful. So this is our homepage. And first, I would like to start by letting you know that if you scroll down just a short distance on the homepage, you will see that you can download a copy of the Patient Education Practice Guidelines, and it's available in either a color format or black and white. It is around 100 pages, but if you would like to have a hard copy, that is available for you. So I wanted to let you know that. And over here to the right, as you look at the page, you'll see the bar for patient education guidelines. So we will click on that and we'll just take a stroll through the guidelines. So as we identified the 4 components of the patient education process, I think Carolyn just summed it up really well when she talked about being thorough and being concise. It was a constant challenge in this process because we wanted to make it very usable and user-friendly for people to have as a reference, but we wanted to be thorough. So in the bold letters, you will see the points that we wanted to highlight, because if you're involved in patient education, you probably, like us, think it's all important. So we tried to keep that in mind and really focus on what are the true key points we wanted to emphasize. So we have an overview of the 4 components of the patient education process. And then we talked a little bit about the overarching elements within those 4 elements of the process. So we thought it was important to say that it focuses on our whole process focuses on being patient-centered and on patient engagement. This really needs to have the patient involved in every step of the process.
Jeanette,
And yes,
Jeanette, I'm going to interrupt for a second just to add into what you're already saying. What struck us is that we kept going through the literature. We're like, well, and we were trying to figure out how to do this. We're like, well, each section, it says assessment to be patient-centered. It says implementation to be patient-centered, blah, blah, blah. And so we're like, well, how are we going to handle that? Because that's really repetitive. This will be dumb. People will be reading this, wondering what we're doing. So after a while, we were like, well, duh, it's like in every single section. So that's how this really became the overarching elements, because it kept coming up in all the articles that we were looking at. So thank you, Jeanette, for letting me interrupt.
yes, no problem. And you will see a little bit of repetition, but I think the repetition you see will be the themes. And so you see the themes that are important, just the philosophical themes of what are the best practices that we found. And those best practices include using plain language and focusing on behaviors and actions, not just knowledge. And best practice combines all of these elements. It's an interactive process, and it takes into account the patient's priorities. So we've laid this out as something of a linear process, which it is. And at the same time, we recognize that it's an integrated process. You do more than one of these things at once, but it really helps to look at each individual segment to see what are the key components, what are the really important parts of the process. So then you can put it all together at the end. So it's a really good review and overview to have as a reference guide. We have a page of frequently asked questions. It is the who, what, when, where, and how of these guidelines, how they came to be, where they came from, why they matter. So we do have that document available. And then the part that I will focus on is the assessment planning, implementation, and evaluation, just to go over how it's laid out, what is included in these sections. So we'll open the assessment section. And you see, this is a consistent theme with the 4 elements of the process. We have a paragraph to describe what is it that we're talking about, how do we define assessment, and then we have the critical steps. Assessment has 5 steps, and you'll see that the remaining ones have 3 steps. So we list the steps, and then we break down the steps into sections where we talk more in each one about examples, sample scripts. We give you a reference list so that if you want to go and look at articles to find out more about any of these elements, you can click on this and go find that list of articles. You can go back to the home page at any point. This is a clickable item that you have throughout the document. So let's look at assessment. What is it that we need to assess to do patient education? The socio-demographic information that you can typically get from talking to the patient, talking to other healthcare providers, as well as the support system, the culture, values, beliefs, and barriers to learning. That's a lot in one step, but those are the things that we felt were important to include in the socio-demographic information. Assess learning needs based on current health issues, knowledge, and worries. Assess patient engagement in the learning process. What are the patient's goals and priorities and motivation to learn? Assess their learning preferences, and then consider using specific assessment tools. If you need extra tools, if you're not getting all of the information that you need, you may need to access some tools a little bit further. So that's what's included in number 5. So if you look down at number 1, where we talked about up here, socio-demographic information, you will find how to collect this information. And it has some of the typical things that we think of with socio-demographic information. We included social determinants of health, and you probably recognize there are far more social determinants of health than this, but these are some examples. And then we have some sample scripts, explanations, just to give you a starting point or to give you a way to maybe ask questions in a way that you might not have thought of before. You can certainly add your own to these. You probably look at these and think, well, I have tried this as well, or this works for me. But again, we wanted to make it concise and informative and give you a starting point and just maybe a new way to think of a question or a way to start some of these conversations. And again, if you click on list 1, just to show you, this is the references, and they are in alphabetical order by author. So you can see that reference list. And then I'm going to try to move my Zoom bar so I can close this list out here. And you'll see that some of your references do give you another place to go where you can actually get more information. It takes you to live sites where you can get even more documents. So you have many references at your disposal. So we can go back to the guidelines homepage. That's one way to get there. And then the question, item number 2, assess learning needs based on current health issues, knowledge, and worries. Address the patient concerns and priorities first, then knowledge and physical abilities. So how do you do that? How do you assess patient concerns and priorities? And these are some of the questions that we found to be useful when we poured through the literature. What are you most concerned about? What do you do at home now to care for yourself? Do you know anyone who has this condition? What do you know about caring for someone with diabetes, with your condition? Fill in the blank. Patient engagement. Assess the patient's confidence related to adhering to the plan of treatment. The patient's feeling of self-efficacy. So some of the ways you could assess that are listed here. After you've had some of that initial conversation with the patient, based on our discussion, here are your top 3 concerns. What would you like to learn first? Really focus on what their priority is at that moment. On a scale of 0 to 5, 0 being low, 5 being high, how would you rate your confidence that you can follow your instructions and care for yourself at home? What would you do if you have questions or doubts? And then for learning preferences, I think we're all pretty familiar with the concept of people learning in different ways, but this gives us a way to ask the question, how do you learn best or prefer to learn? By reading, by having someone demonstrate, by you doing a hands-on repeat back demonstration, a video, verbal instructions, technology, and assess what kind of technology have they used? What are they comfortable with? What would they prefer? And then the 5th tool in this section addresses specific assessment tools. So whether that be pre and post tests, knowledge behavior assessments, those are listed in the appendices, and you can click on those and get more information about those various tools. Motivational interviewing, if you want to brush up on what some of those questions might be, you can go to Appendix 4. So that's the first one, and that's where I wanted to spend more time, just to show you the columns and what's available if you click on each section. And then we get to the planning stage, and we have the overall definition. The healthcare professional and patient partner to develop a plan. It's important to consider the patient's unique learning needs in the assessment. And it's critical for the healthcare professional to have the knowledge and skill to implement those patient education strategies and to identify goals and priorities. And so again, this one has just 3 steps, but this is one of the really more involved places that we have, the sections that we have in the guidelines. And again, there was so much conversation about planning and implementation because they're so intertwined. So we put the bulk of the examples and scripts in this section, but you'll find they are very, very interchangeable with implementation, depending on how you've set it up with the patient. So the first step, use all aspects of patient assessment information to guide the development of mutual educational goals. The second one, develop the teaching plan using evidence-based teaching strategies, easy to understand language, multimodal approach to individualize it with a focus, again, on the patient's needs, priorities, and behaviors. And third, identify educational resources to achieve the learning goals. So consistent with number 1, use all aspects of patient assessment information to guide plan development and determine mutual educational goals. And in the planning steps on this section, this is where you find some of the how-tos. Partner with the patient to develop those mutually agreed upon goals. And they should focus on behaviors, be clearly stated, action-oriented, measurable. If you're familiar with SMART goals, if you've used those in any of your settings, this is very similar to the concept of SMART goals for patient teaching. So these are a couple of examples. The patient and the healthcare provider develop a diabetic diet. The patient chooses the type of carbohydrate to eat based on their preferences and what makes them feel less sluggish. So it's based on their real lived experience. The patient, and then another example, the patient will learn the skills needed to demonstrate the following behaviors. Check blood pressure every day when you wake up, take your blood pressure medicine each day. Individualize, tailor the education. Education meets patients' individual health literacy needs, such as a patient with a disability who needs recorded instructions, understanding through that initial assessment, what is it that this patient needs presented in a unique way. Education is approached in a culturally sensitive manner. So, for example, patients are given a diabetes diet information based on the foods they normally eat. Consider the preferred language. Include the family, caregiver, or significant other whenever possible. Who is it that will be helping to support that person? Build on their current knowledge. Based on what we've discussed so far, based on what you told me, reinforce, you know, the basics. Let's talk about the next steps and how this will affect your day-to-day life. Use motivational interviewing, which includes the ORS method, open-ended questions, affirmations, giving positive feedback. You're doing well with this. Reflection, mirror the patient's statements, and summary, summarize what the patient has said. This next section gives some guidelines for considering the educational setting. The conversation that you have and some of the tools that you use might be a little different in primary and outpatient care than they are in preoperative care, acute care. When a patient is an inpatient in the hospital, the discharge, the last session, would be a place where we would want to include opportunities for structured education, include teach back to make sure that they have the essential information, and content reinforcement. Education in all settings really should include teach back, content reinforcement. So that question of what would you do if you gained more than 4 pounds in 24 hours? Help them determine what would I do if there was a problem, and you pick whatever problem that might be based on what their situation is or what the setting is. Develop the education plan. Teach all patients in a manner they can understand, and these are some resources for that. Use simple direct messaging, avoid medical jargon, common everyday language. Identify content and the key message to support learning objectives. And so these are some stepwise instructions, one step at a time. Keep the message focused. Educate in small segments. Chunk and check is a strategy that many of our researchers recommended. Take small chunks of information, check for understanding before you move on to the next piece. Identify patient behaviors to demonstrate knowledge. Patient demonstrates very specific actions and behaviors. Employ effective communication strategies. Consider how you might be able to share some of this information with other staff in effective communication strategies, for example. Active listening. How do you build rapport with the patient? How do you find out what's important to them? Promote self-efficacy, skill mastery. Use team-based approach. Use physicians, pharmacists, everyone who comes in contact who was in a position to teach the patient in any situation. And these are the different approaches. A multimodal approach is using more than one teaching strategy at a time. For example, when teaching verbally, provide a written handout. Use a multi-sensory approach, engage as many of the patient's senses as possible. For example, auditory, visual, tactile, smell. Use a multi-prong approach. Offer the same education in multiple formats to meet those learning preferences that you assessed earlier. So the patient can select which way will work better. And sometimes it's a matter of whether they want that support person with them, whether they need alone time, whether they need someone to explain each step as they go through it. It depends on what that patient's needs are. And have repeated contact with the patient to reinforce teaching. And that repeated contact may be different healthcare providers, healthcare clinicians to help reinforce that teaching. Use problem-centered learning. Patient knowledge is gained through solving real-world problems. What would you do if? Can you demonstrate? Can you show me how you would do this step? Use experiential learning. role modeling, performance, use analogies. Adults love analogies. It's a great learning tool. Use personalized action plans. So Carolyn, the next last two sections are fairly short, and I don't want to cut us short on time for the breakout. So how much time would you like me to speed this part up a little bit?
Yeah, I think we can go ahead and speed up this part. It's pretty self-explanatory.
Yeah, but really the point of this was to get you accustomed to how the guidelines are laid out. So for each section of assessment, planning, implementation, and evaluation, you see a similar layout. We added education concepts and models at the end of this section, again, to recognize that there are some great models for education out there. You may like some of these models a lot. Some of them may be new, and it's just a way to get access to those to see if there might be some that you have not used before that could work really well. Implementation, again, we have the 3 steps: focus on the patient, keep the key principles of patient education in mind, and the most important one here is adjust your teaching based on the patient's response or changes in learning needs or changes in their situation. So that's the key element that's really important in this step. Again, we talk about plain language, active listening skills, teachable moments, frame the message, reinforce. So some of this looks similar to what was in planning, but it does take it a step further with some of the steps like the dressing change and explaining exactly how you would teach that to a patient and how you adjust the teaching, how you use analogies, and it has some more examples for that. And then evaluation demonstrates the degree to which learning is achieved. How can the person apply information to problem solve in both the hypothetical situation that you're teaching, and so that you know that when they get into the real world situation, they'll be able to apply it. So it's important to evaluate the degree of learning, to use scales when you can, on a scale of 0 to 5. How comfortable are you with knowing how to do this particular step? After each concept is taught, chunk and check. Teach bits of information, check it first before you move on to the next part. It may be necessary to reteach using different methods, different resources, if it's not staying with the patient, if they're not able to really articulate or to demonstrate what they need to know. So the steps in evaluation are to evaluate using the teach back strategy, evaluate learning of skill and behavior through return demonstration, and evaluate learning by measuring a change in patient outcomes. And there are some examples and explanations in this section of how you would do that. Some ways to phrase teach back questions so that it's not intimidating to the patient, so they don't feel like they're being tested. Return demonstration, it gives you some examples of how to interact with the patient doing the return demonstration. And then the measurable change in patient outcomes. Think about how you would interact with the process of managing those patient outcomes in your organization. Who would you work with to be able to access some of that information to really see over a period of time what those outcomes might look like? There is a place where you can click directly on the appendices. We have the references by list, references alphabetically. There is a guidelines quick guide that's a little 2-page summary that you could print and have available. And then we do have, as I said, the black and white or the color PDF of the entire guidelines. So I will stop sharing my screen. And at this point, we actually have a breakout session for you. So Carolyn, if you could pull up to the PowerPoint again.
I am doing as we speak.
So this case study, we purposely didn't include a lot of details in this. We kept it pretty general so that you could be creative in your thoughts about how to approach this. But this is a 30-year-old patient, 30, with who's having a left knee arthroscopic procedure. And the patient's main concern is that he will have uncontrolled pain due to the opioid prescribing restrictions. He's heard that it's really difficult for physicians to prescribe opioids, and so he's worried about pain. So in your breakout groups, we would like for you to talk about how might you use the guidelines in this case study. Very open question. How might you use them? And we'd like you to look at it from an organizational perspective. What are the organizational policies and practices? And from the bedside practice perspective of the caregivers who are right there with the patient.
So how would you apply the guidelines from an organizational and bedside perspective to figure out how you would educate this patient? So at this point, they're going to put you into breakout rooms, the magical tech guys behind the scene here. There are going to be about 5 or 6 of you in each breakout room. You're going to have about 5 minutes to discuss this. If you want to appoint a person to report back to us, or we just may have you come back in and just give us some information, because we do have a second breakout we'd like to do before we disperse for this afternoon. So if you want to put us in breakout rooms, that would be great.
And there they go.
I can't see them going.
Oh.
Yeah. And then whenever y'all are ready to send them back in, let me know and I can pull them back in.
Okay.
Okay, that's great. So we'll give them a few minutes to discuss this. He asked whether we could go, but I said only if you floated us. So I guess we're going to stay put.
Yeah, I think so.
The slideshow was kind of wonky when I went to go start it. I don't understand. Yeah, that was weird. Cindy, are you still with us? I see Cindy's picture.
I did send Cindy to a room, but they did not want to join. Oh, so I can force Cindy to go over if you want me to.
Cindy, do you want to go to a room? I guess send her. She may want to hear what they're saying.
I loved your update on the usage. I think that's really encouraging. I hope lots of people are going to the guidelines, maybe in preparation for, for this session. What are these things? What are these guidelines?
Yeah, it's nice to see those numbers.
Yes, it is.
It's afternoon snack time.
Yes. I remember.
Oops, I'm sorry to interrupt. And we're supposed to end at the half hour. Is that correct? So whenever you want to pull them back in, just let me know.
Yeah, I was giving them like another minute.
Okay, cool.
And we're recording as I'm talking about snacks here. That's probably not okay. You're going to edit that, right?
Yeah, we'll make sure to get that.
Very good. Yeah, I looked at that going, oh, talking about snacks, and it's recording. Well, thank you very much. This seems to have been a very smooth session from a technical standpoint. Thank
Yes, thank you.
Yeah, for sure. That's what we're here for. What we try to do, at least. Sometimes there's little hiccups, but
you.
that's normal with technology and internet and stuff.
Yeah, we're really familiar. We had a conference recently. We had a few hiccups. So they've been in about 3 minutes. So we ended up with about 9 or 8 different groups.
Yeah, I have 6 groups. Each one was supposed to have 4 or 5. Some of them left before I moved them over. So some
No.
have 2 now. So
Yeah.
Okay.
So maybe we might just talk about the breakout too as a larger group.
So
see.
how many participants, let me see, are we down to now? Do you know total? Because at one point we were up to 44.
yeah, that's the last number I saw too before everyone left. So well, not everyone, but some left completely.
Didn't want to stick around for the breakout. Well, Jeanette, we've learned a lesson. No breakouts. You know what? You can start pulling them back in.
Alrighty, I will pull them back in.
Thank you.
Cool. So all breakouts room will close in 56 seconds. So that cues them to start heading back into the main room. So those should be trickling in pretty soon.
Yeah, and I think that last one, we'll just have them use the chat feature. We'll see
Yeah.
how many participants are left.
Yeah, so in this, they can actually turn the cameras and talk to you also if they want to.
Oh, great.
Sounds good. Yeah, we were doing it based upon the number. Hi, Sandy. I was going to say, Jerry Lynn, how are you?
I'm muted, sorry. Hi.
Hi, nice to see you.
You too.
We need to talk. I'm ready to start talking to you.
I'm always here. Just let me know.
Okay, we're going to set up a conversation.
Now
Sounds good.
everybody's curiosity, Kelly.
Hi, Cindy.
Cindy, Jerry Lynn has a tool that she's offered to help us promote the guidelines, and we were doing our own thing here initially off the ground, but now I want to talk to her about it again. So
Jerry's a great promoter.
So Cindy, did you end up in a room?
I did not. So while you were giving the instructions, I had a puppy call. For the first time, I have a new puppy, and she went out on a little puppy, party, and she's all wet and excited and kind of needed a little toweling off. So I had to excuse myself from the breakout.
Very good. All right. Does it look like we have everybody back?
Yes, that should be everyone that came back into the main room. All the breakouts have ended.
Okay, thank you. So what we learned from this is maybe not to do breakouts towards the end because we've lost about 20 people. But we do want to hear from some of the people, and since there's only 20 some left and we only have a few minutes left, do a couple people want to turn on their cameras and tell us what you talked about? Or Geraldine, you were in a group, right?
I was. We ended up having about 90 seconds to talk, but because we had somebody join our group from another breakout room and there was some
Little
confusion. So we were literally at about 90 seconds.
Well, what did you accomplish in that 90 seconds?
Well, we were just talking about how important it was to find out what their concerns are, like what are the types of things, both about the opioids themselves, right, and the pain management, but also in terms of what is it that they currently can't do that they would like to be able to do, really understanding those like kind of patient goals and doing that kind of motivational interviewing piece. That's kind of where we got cut off. Faith, is there anything you want to add to that? That's kind of all we had a chance to do. But
very good. Is there anybody else who wants to speak up and just briefly tell us what your group discussed?
We were kind of in agreement with Jerry Lynn there that teaching about anything to do with the surgery was really not going to be very helpful initially. And then in the pre-op phase, you probably need to talk a little bit about her fear with the opioid usage and pain control and what that might be like, because she may be tunnel vision and not be able to hear anything you have to say about the surgery unless you attend to her particular focus at that point. So that was where we started is, what do we know, what assessment needs to be done to try to understand where she's at in terms of her fear of pain, and talk a little bit about pain management before you go on with anything else.
Okay, well, thank you very much. And to wrap this up, because we just have a couple more minutes, could you put in the chat, or if anybody wants to speak, that's fine. How do you picture using these guidelines as you look at your organization or your particular practice? What do you picture doing with it? And you can just put that in the chat, or it'd be great. Well, some people do the chat and other people want to talk, however you want to do this. Do you have anybody who wants to chat, talk out loud? The quiet group. I'm looking to see if anything's coming in the chat. We
sorry, I guess
no,
I'll
go right
chime
ahead.
in. Not so much about how to use the guidelines, but something we also discussed was just the need to make sure that there's some cultural training, I guess, with your staff and even implementing the guidelines, because I think sometimes there is, like say in this example with pain, there are sometimes preconceived notions or biases about which groups tolerate pain better, which ones don't, who is overinflating maybe pain and things like that. And so just, I think having the guidelines there is good, but I think also making sure that you have that cultural awareness that is, and not even just awareness, like that you're checking your biases and not assuming whether they're young, whether they're old, whether they're women, whether they're Black, like that, or another ethnic minority, that they can tolerate pain more, or that they're lying about their pain. So as you stress the need for teaching a patient how to assess their pain level, I think just making sure that you keep that in mind as well.
And we had an interesting discussion about how far to go with culture and all of those values and culture and sensitivity and cultural humility. And we chose to go the direction of get to know your patient, because sometimes we don't want the stereotypes like you had just mentioned to be there. So if you really get to know your patient to teach them, that's really the key. You can see some people in the chat here. Yes, cultural humility is key. I want to use it in research I'm doing with patients with rare disease. Agree, this may be something to add to the guidelines if it's not present. So it's actually, we do talk about culture, but the emphasis is get to know either the patient population or the individual patient. And I do realize that we are at 3:30 now. I did want to say that we did not have an opportunity to pilot this with organizations due to COVID, and that continues. We keep searching for organizations that may want to pilot and apply it. So if you work for an organization that'd be interested in that, we would love to partner with you. But thank you very much for joining us. Jeanette, do you want to send us off here?
Yes, just thank you for your participation and your comments. We really appreciate any feedback that we get. It's all very helpful, and we're just happy that you spent this time, and wish you the best.
Thanks, everybody.